Every year, more than 100,000 people are diagnosed with leptomeningeal cancer, and yet we do not have the tools to prevent, diagnose, or treat this disease. The Leptomeningeal Cancer Foundation is here to change that. Working with medical experts, researchers, patients, and their families, we will raise awareness, educate patients and healthcare providers, and support research. Please visit us at lmcancer.org and follow us on social media. We are here to support you and ensure that you never feel alone. Hi, everyone. Welcome to our very first webinar. We are so grateful that you took the time out of your day to join us. I am Helene Bader. I'm the founder of the Leptomeningeal Cancer Foundation, and I started this organization in honor of my amazing son, Theo, who died last February at the age of 17 from leptomeningeal spread started by melanoma. And as many of you know, information is really hard to find. And so my goal is to create an organization and education around this disease and build awareness. Joining me today to help moderate the Q&A is Kyle Greenmeyer. Many of you know Kyle from her leptomeningeal disease community support group that she started on Facebook with her sister Brianna, who also, like Theo, was diagnosed with melanoma and had leptomeningeal spread. So we are both here today honoring Theo and Brianna and honoring and supporting all of you. So now it is my great honor to introduce our amazing presenters, two leaders in the field of leptomeningeal disease. Dr. Adrienne Boire is a neuro-oncologist and a scientist at Memorial Sloan Kettering Center in New York. Dr. Boire cares for patients with metastasis to the central nervous system and conducts clinical trials targeting these tumors. As a scientist, she leads a laboratory-based research team focused on metastasis to the central nervous system, which includes leptomeningeal disease. Dr. Boire serves as the scientific director of the Alan and Sandra Jerry Metastasis and Tumor Ecosystem Center, and she's the Jeffrey Bean Junior Faculty Chair. Welcome, Dr. Boire. And Dr. Isabella Glitza is a melanoma medical oncologist and the director of the Melanoma Medical Oncology LMD program at MD Anderson Center in Houston, Texas. In addition to a regular clinic, she also staffs the MD Anderson Brain Metastases Clinic. Dr. Glitza is also a clinical investigator whose research focuses on developing immunotherapeutic strategies to improve clinical outcomes in melanoma patients with central nervous system involvement. She serves as the primary investigator on first-in-human clinical trials. So I kept those bios somewhat brief because I wanted to make sure that we got right into the presentations, but you can find more detailed bios on our website at lmcancer.org, and you can also read more about Theo and Brianna's story, as well as more about Kyle and me. And before we begin, I just want to remind everybody that this is an information webinar, so specific medical advice will not be given. Please consult with your physician for answers to any personal questions. And now I'm going to just turn it right over to Dr. Boire and Dr. Glitza to present. So thank you.
Thanks so much, Helene. It's lovely to be here, and good morning, everyone. It's my honor to present and also to get to introduce this topic to everyone. So today we have kind of an exciting agenda. We're going to be discussing leptomeningeal cancer, and we're going to start with some definitions, presentation, and symptoms. We're going to pivot over to how we diagnose this condition, and then really discuss how we manage this disease clinically, the different techniques and modalities that are used, and finally some current clinical trials that may be of interest and ways to get involved. So beginning with the definitions, I think something that many of you have already encountered is that there are a great many ways to describe the same thing. So you may have encountered descriptions including leptomeningeal metastasis, leptomeningeal carcinomatosis, meningeal carcinomatosis, carcinomatous meningitis, leptomeningeal disease, neoplastic carcinomatosis, etc. I think all of them have quite a lot of syllables. And as a result of this, very often we reduce it to either saying lepto or LM or LMD. Ultimately, they all describe the same thing, which is spread of cancer into the leptomeningeal space. We tend to use the terms interchangeably depending on kind of physician and patient preference, but please understand that all of these terms represent what we're seeing here. Could I have the next slide, please? So what are we talking about when we're talking about the leptomeningeal space? So the leptomeninges are the soft coverings of the central nervous system. So the leptomeninges encase the brain and the spinal cord. And they consist of the pia and the arachnoid, and they contain the spinal fluid. The spinal fluid itself is generated by a structure called the choroid plexus, and the choroid plexuses are living within the ventricular systems of the brain, and they generate, of course, the spinal fluid. The spinal fluid that they generate is quite different than serum, and that's why when you examine the CSF just clinically, you'll see that it comes out, it looks quite a bit like water. Next slide, please. So the next question, I think, is really the most important one, which is really how do we know that a patient might have leptomeningeal metastasis? What makes us suspicious about this? Could you take the next slide, please? So the first thing a physician needs to consider is the incidence. So, what's the possibility or what's the probability that a patient may have spread of cancer into the leptomeningeal space? And so, while leptomeningeal metastasis is rare, really only between kind of 1 and 8% of all cancer patients, it really depends on the kind of tumor we're talking about. So if we're talking about a primary tumor such as melanoma or small cell cancer, small cell lung cancer, the incidence is quite a bit higher. The frequency is closer to 10 to 20 or even 40%, depending. And in other tumor types, such as breast cancer, non-small cell lung cancer, or others, it might be a bit lower. Of course, if you are the person who has leptomeningeal metastasis, the rarity of the tumor is sort of less important because it's important for you. It's your whole life. Could you please go to the next slide? One question that comes up quite a bit is what kind of tumors result in leptomeningeal metastasis? And I think it's important to underline the idea that any tumor can result in leptomeningeal metastasis. There's no tumor where we would say this never happens. It might be more rare, but it certainly is possible in any tumor. And so as we look kind of retrospectively over the years, you can see that more and more different kinds of tumors are resulting in leptomeningeal metastasis. And we know that overall, the overall incidence of leptomeningeal metastasis is increasing. Could you go to the next slide, please? So for all of these reasons, clinicians tend to have leptomeningeal metastasis as sort of a possibility when they're thinking about their patients. And so a question often comes up. So what does this look like for a patient? What does it feel like? And what might give me pause to consider this diagnosis? So the leptomeningeal metastasis can present as almost anything. We have, and this is a kind of the most recent examination of this, and you can see that patients can have headaches, they can have cranial neuropathies, they can have weaknesses. Could you please go to the next slide? Could I have the next slide, please? And so very, very often this is described as a protean manifestation of cancer. And the reason for this is that it's sort of a shape-shifting, right? But the idea is that you can't say there's one particular presentation of leptomeningeal metastasis. And so patients who have neurologic symptoms, we very often think of it as something that is always on our mind, meaning it's something that's always in our differential diagnosis. And this is why we sometimes refer to it as the Willie Nelson diagnosis, right? Because it's always on our mind. So I've listed here some of the symptoms that can result from leptomeningeal metastasis. Could I have the next slide, please? So when we have the inkling that leptomeningeal metastasis might be a possibility, we need to address how do we diagnose this condition? Could I have the next slide? So diagnosing leptomeningeal metastasis is actually pretty difficult. It requires several steps. We need, of course, to do an examination of the patient. We need to meet the patient. We do a neurologic exam. And then we also need to do imaging. In this case, we'll talk about that next, MRI imaging, and then we also need to examine the spinal fluid. And when we do both of these things, the imaging of the central nervous system as well as examination of the spinal fluid, those two things together allow us to make the diagnosis. Could I have the next slide, please? So after MRI scan, we're able to see some aspects of leptomeningeal metastasis by MRI. So there's some kind of classical patterns that we see, and you might see on reports from neuroradiologists. So you can see here in A, B, and C, these are MRI scans from a patient with leptomeningeal metastasis. And you can see in A, you can see enhancement, meaning that these are areas of the MRI that are taking up dye. And you can see that there's white areas in the back of the brain. I'm not sure if you can see my cursor, probably not, but you can see those stripes in the back of the brain. And those are areas of cancer that are sitting on top of the cerebellar folia, meaning the back of the brain. In B, this is the base of the spine, and you can see those speckles in that trapezoidal area. That's the spinal canal. Those are the nerve roots. And then in C, you can see that same area, this time in a different view. And in all of these, what we're seeing are areas that are taking up dye. They're taking up gadolinium contrast in such a way that that gives us concern that there may be leptomeningeal metastasis. Unfortunately, MRI is wonderfully sensitive, but it's not perfect. So the sensitivity of diagnosing leptomeningeal metastasis by MRI really varies quite a bit. I give here 70 to 100%. It really depends on the study. It depends on the patients that are being examined, the magnet, who's reading it, quite a number of things. Could we have the next slide, please? So the problem, of course, is one of specificity. So this is listed here are the what we would call the differential diagnosis for leptomeningeal enhancement, meaning whenever we see those lines of white on the outside of the central nervous system, what does it mean? You can see here that there are a lot of processes that can result in that leptomeningeal enhancement. Could I have the next slide, please? And you can see that, oh, could you go back one? Thank you. So I've boxed in here some relevant issues for patients with cancer. And you can see here that if, let's say, you've had checkpoint therapy, or if you have an autoimmune process, that can also lead to leptomeningeal enhancement. And so we can't use MRI alone to make the diagnosis. Could you go to the next slide, please? And so for this reason, we take a look at spinal fluid. And spinal fluid analysis, looking at the CSF, this is the gold standard for the diagnosis of leptomeningeal metastasis. And what you're seeing here on the left is what spinal fluid can look like underneath the microscope when we can see a patient with leptomeningeal metastasis here due to melanoma. Unfortunately, cytology is not terribly sensitive, and so there's been a lot of work to try and improve this. Could you advance the next slide, please? So when we look at CSF, sometimes we're looking at all of the tests, right, to be able to see if we can glean all the information we possibly can get. And some of the most basic tests that we get are the chemistries of the spinal fluid, including the glucose and the protein. So when we look at the glucose levels, we're looking to see if the glucose levels have dropped. A normal glucose level is about 2/3 of the blood glucose, and that's usually between 45 and 80. And when patients have low blood glucose, that makes us concerned for an inflammatory process. And when you see here on the right, you can see the what I would call the differential diagnosis for a low CSF or CSF glucose. And these are all inflammatory processes. Could I have the next slide, please? The protein level is the next CSF chemistry that we look at. Normally, the level of protein in the spinal fluid is between 15 to 45, but usually it's around 40. And inflammatory processes, including leptomeningeal metastasis, they generally increase the CSF protein levels. And that's because the CSF is circulating and it's accumulating protein during this inflammatory process. So those two basic chemistry tests already give us a little bit of suspicion that there might be cancer in the leptomeningeal space. Could I have the next slide, please? Then we can look at the cells that are in the spinal fluid. In the absence of cancer or any disease, normally the CSF does not have any cells in it. Normally, we would see less than 4 cells per millimeter cubed. As inflammation increases, as cancer enters into the space, we see the cell count increase. And so a suspicious cell count of between 5 and 10 cells per millimeter cubed is concerning to us, and abnormal is anything over 10. And influx of the immune cells is always a sign of some kind of pathology. It may not be cancer, it might be autoimmunity or a frank infection, but it is something that is worth taking note of. Could you advance to the next slide, please? So when we're looking at these cells, we need to identify what the cells are. Are they immune cells or are they cancer cells, right? So the most basic way to do this is cytology. And as I said, cytology, of course, is our gold standard. Unfortunately, it has a very low sensitivity, but reasonable specificity, and is very, very good at identifying cancer versus non-cancer cells. Sort of the next stage of testing is something called flow cytometry, and this is something that most hospitals can do. It's based on the surface markers on the surface of the cell, and it's really very sensitive. You really need to know what you're looking for, however. It's really very useful for patients that have different kinds of blood cancers like leukemias or lymphomas. We're very, very good at identifying cancer cells in the spinal fluid using flow cytometry for these patients. Patients with solid tumors, we've had a really hard time using flow cytometry as a way of identifying these cancer cells in this space. And so this is why sort of the newer school way of doing this is with circulating tumor cells. Many cancer centers can do this, but this testing is sort of still in progress in terms of its availability. And because it's based on surface markers, it can be very sensitive, but it's really suitable for very few tumor types. So in this case, the example I'm using here is for EpCAM positive tumors, and that would be breast and lung cancer. So tumors like sarcomas or melanomas or certain primary brain tumors, all of those tumors would not be able to be identified by the circulating tumor cell technology. And so once we've diagnosed leptomeningeal metastasis, then of course the question becomes what we're going to do next. And from here, I will pass the baton over to my wonderful colleague, Dr. Glitza, who will take you through some of the ways that we manage this disease.
Thank you, Dr. Boire. And again, I would like to say thank you for having me today and for dialing in. I do recognize some names in the participant list. So again, thank you for dialing in. Thank you for having me. I think for the last 20 minutes, you already heard about some of the struggles that we even have as physicians who see a lot of LMD patients in our daily practice to really say you do have leptomeningeal disease. And again, some of the folks that are on here today might have heard me say in the past, I'm not completely convinced, but we need to monitor, we need to look closer because the suspicions is high. And as you can see on the slide that Dr. Boire just shared, we are learning more and more about the what we call leptomeningeal disease space, kind of this whole spinal fluid area, and really trying to have new technologies that again are not usable in all cancer types yet. Like we just talked, only EpCAM positive tumors, but again the hope is that with a increased focus on this complication of cancer, we really will make some headwind sooner rather than later to help more patients in a meaningful way. Next slide, please. So the goals of treatment are really very simple and straightforward. And again, this is a slide that Dr. Boire created. She always has the best slides. But obviously, we want to control the macroscopic disease. That means what we can see on the imaging. But we also want to obviously prevent microscopic things that we can't see it from growing and become potentially new areas of issue. And then again, we have the systemic disease, right? We've been focusing on this talk today really again about this leptomeningeal space, but we can't really forget that the patient typically comes with other metastases, either in the meat of the brain, which we typically refer to as parenchymal, or also in the rest of the body. and obviously preserving function, specifically neurological function, as you saw the extensive list of potential symptoms that patients unfortunately might suffer from. It is really important to palliate as much as we can. And again, while we do all this, and I think this goes for any stage cancer, we do need to preserve quality of life. So these discussions need to be tailored to the specific patients and cannot be generalized with, just one simple statement or line. Next slide, please. So what's the survival, though? I think we talked about symptoms. We talked about some of the challenges with the diagnosis. But I think, unfortunately, and again, this is why I'm glad you all joined today, is that we need to do better. And when I say we really look at the medical community, but also support from pharma, support from patients, and demands from patients, because the median overall survival, and again, you will see different data in the literature, but this is just a quick summary of some of the retrospective analysis that have been done in different tumor types. And what you unfortunately can see that we typically measure leptomeningeal disease survival still just in weeks to months. If left untreated, and again, these are patients that again typically presented with new symptoms, they might be really sick and declining rapidly, the survival is again typically less than 2 months. And again, even if we treat patients in average, the survival is maybe just about 8 months. But again, the good news is that some patients these days with newer therapies and having different therapy approaches available for them, we can extend the survival. But again, clearly so much more work to do, and we can't just accept the status quo. Next slide, please. So again, the principles kind of along this control and to look at symptoms. So again, we need to find out where this is coming from. And again, during the workup, we do perform the MRI brain and the spine to really look at the whole craniospinal axis as referred to. And if there are points that are causing significant pain, for example, or neurological deficits, we can use, and we'll talk a little bit about this, focal radiation potentially to these stops. To these areas. We also need to understand, do patients have generalized, weird, crazy, horrible symptoms with nausea, vomiting, horrible headaches, because the intracranial pressure is elevated. And what that means is that the CSF is really building up, it can't flow. And again, I'm stating something's very simple, but we might need to have some pressure check through the lumbar puncture, really understand what the pressure might be, but also might need to do an eye exam to see how the back of the eye look like, how do the nerves look like, are they swollen? Again, some patients present with seizures, and sometimes these can be really pesky and difficult to control. So sometimes we need more than one anti-epileptic agent. And again, as I said, the local treatment is really, again, can we focus on one particular area and alleviate, knowing though that we still really need to control or treat the whole craniospinal axis. And again, systemic treatment means treat again what we can't see yet, but with the hope that we can avoid these from becoming bigger and larger and causing more symptoms and disseminate. Next slide, please. So as I just mentioned, so sometimes we unfortunately see patients that have something that is called elevated intracranial pressure, or something called hydrocephalus is another word that we use. And these patients can't just, through drugs, they can't really wait and hope that these symptoms just resolve themselves. This is where a neurosurgeon, who we don't have on here today, could be extremely helpful, because what they can do, they can place a drain. It's called a shunt. And the way that the shunt is placed on this graph, as you can see, it's being placed in one of your lateral ventricles, and it's really just a fancy tube that goes all the way down to your peritoneal cavity, kind of your belly area, and it can just drain the CSF that's being produced and not really circulated and building up pressure within the headspace particular. It is an excellent palliative relief. Most patients, once this drain is placed, really report improvement within hours potentially. Again, it can help some of the symptoms that we just otherwise can't help with. And really, we need to do this in these particular patients. Again, this is not for everybody with leptomeningeal disease. If we want to initiate any therapies, because some of these therapies, as you will in some of the other sites, can increase the intracranial pressure, can cause other symptoms. So we want to obviously fix what we can fix right now. RT stands for radiotherapy, that can also raise some of the pressure within the brain. And again, as it says, we always want to do things proactive if we can, or immediately reactive instead of waiting to do things on an urgent basis, which, as we all know, is never the preferred scenario. Next slide, please. So I just spoke about symptomatic lesions. And again, this is, again, a slide from Dr. Boire, which I think is a good, nice little summary of what we do. So you all probably have heard that we use dexamethasone for patients with not only leptomeningeal disease, but brain metastases as well, especially if they're symptomatic. And again, while some places might have a slightly different doses, I think, again, this is a very good initial cookbook or recipe for how we treat. So again, dexamethasone is a steroid that is penetrant into the spinal fluid as well as in the whole craniospinal area. And the dosing is typically about 4 to 8 milligrams times 1. You often see also just 10 milligrams times 1 given. And then we try to go down to every twice a day dosing. Sometimes, again, it needs to be every 6 or 8 hours, again, depending on the symptoms. Again, radiotherapy or radiation therapy can be given to symptomatic lesions. And again, if a concern is that the intracranial pressure is high and patients might need a shunt, again, this typically should be started or to at least initiated in the house. And again, if urinary retention or new leg weakness, again, this is something that is an urgency and emergency, and that would, for example, include radiation to the lower part of the spine if there's a lesion there. And again, whole brain radiation, and we'll have a few slides about radiation in general, not necessarily just whole brain radiation, but something called proton craniospinal radiation, again, can be given to palliate symptoms. But again, whole brain is typically only done once, and again, treated in combination with dexamethasone. Next slide, please. So now we're switching a little bit more over into clinical management and are covering some of the drugs. And again, I know we could go on for many hours over the next slide, please. But I think what we tried to do today is just giving you a quick overview of some of the things. And again, and we can further build on this in the future. But again, we need to treat the entire compartment, right? So we talked about the macroscopic disease that is maybe causing symptoms. We might have zapped this, or we might have alleviated symptoms. But how do we now treat the patient as a whole and the entire compartment of, again, the CSF? So again, I mentioned earlier already the proton craniospinal radiation. And we'll talk in a few seconds or a few minutes about what this actually means. But again, patients have to have a normal intracranial pressure. They cannot have a impending or ongoing hydrocephalus. Typically, the age needs to be younger. And the reason why this is because every time we radiate the whole brain, it can lead to some cognitive decline. And the younger the patients are, the typically better their cognition can be preserved. We use other strategies to also help with that. But again, we require typically a younger age and what we call a good performance status. Now, intrathecal, again, is treatment given directly into your spinal fluid. And again, we also prefer to have a normal intracranial pressure, a normal CSF flow. We sometimes use something called a flow study where we inject radioactive nucleotides so we can actually really see if there's any blockages, and this is typically done over a 24-hour period. And again, the problem though is then if we give intrathecal therapies, it really doesn't penetrate, at least that we know of, into the meat of the brain called, again, the parenchyma, so really brain metastases versus LMD, and it clearly doesn't penetrate also if the leptomeningeal disease is very thick. And if you remember the pictures that Dr. Boire showed earlier on the MRI, we see that some LMD, so everybody is again very different. So some LMD is nodular. It looks like little rice corns were thrown onto somebody's soft tissues that are lining, again, your brain. Some patients have this very thin diffuse, I describe it as, sugar or powdered sugar just coating of their nerves or of their parts of their brain. Some have maybe little spots, like little mushrooms. Again, I apologize if I'm using weird words, but little tumors kind of deriving from inside of those liquid-filled pockets inside of the brain. So again, everybody looks different. But again, if you have very, very bulky disease, then intrathecal by itself will probably not work. Systemic refers to something that we give either by vein or by mouth. And again, the important part is, though, that we need to have these drugs getting into the brain, or have knowledge about these drugs actually penetrating the CSF and the brain. And of course, we both are at centers that are clinical trial and research heavy. We do prefer clinical trials where available, because again, we realize we need to push the field forward and not just accept the status quo. Next slide, please. So proton craniospinal irradiation has really been around for quite a while, but it really hasn't been used for leptomeningeal disease in adults until recently. And so just as a quick summary, and maybe we'll look just at the lower corner, because I think this is a very good graph. So we typically have two different types of radiation that we use in patients with brain mets or LMD. Photon beam, which is more conventional radiation, think of whole brain radiation. But then we have proton beam radiation therapy, right? And so when you look at this little human graph at the below, and you look at the tumor kind of in the middle of this patient's body, when we use proton, it can really deposit the bulk of the energy where we want it to be, right in the center of the field that has been designed by the physicists. Now, if we use conventional radiation therapy, you can see that there's a lot of entry dose that is really high, but not all is really getting into the tumor. And importantly, a lot is even passing kind of through the tumor and can cause other issues and side effects with the organs that are kind of in that area. There is some data that has, again, been done at Sloan a few years ago now, using this, again, proton radiation craniospinal. So we're radiating, again, the whole craniospinal axis versus, again, whole brain radiation, initially in patients with non-small cell lung cancer and breast. And again, you can see that both what we call the progression-free survival and the overall survival benefit was seen with this. However, again, while this is exciting, and while I would call that this is definitely true, I would like to again highlight that the overall survival with proton craniospinal radiation was only about 10 months. So again, this is not a cure, this is not a blockbuster, but should be considered as an important tool to discuss in our regimen for treating LMD. Next slide, please. And yes, as I said, LM progresses rapidly, so we can't typically sit around and wait. Now, the problem, though, with proton CSI is that the planning and treatment initiation takes time. And unfortunately, sometimes, and I can tell you at MD Anderson, and this fluctuates a little bit, but the time to actually be able to do craniospinal radiation with proton can take up to 4 weeks. And again, there's a lot of proton centers that are not accessible to everyone. And again, unfortunately, insurance also doesn't approve this for everybody. And again, it's very clear that not all patients can and should wait for proton CSI. Next slide, please. So now let's switch focus onto intrathecal. So right, this is right into the spinal fluid. And the way that we can get into a patient's spinal fluid is by two ways. One is the Ommaya, which is like a little port that we just implant right under the skin. And people have like a little button that again is protected through the skin. Again, we need to have the good CSF flow. We kind of keep on mentioning this over and over. And the other area would be through lumbar treatment, which obviously doesn't require any operation, no neurosurgery, doesn't have a permanent hardware in place. And again, we really need to always think about, though, does the drugs, when we inject them into the lumbar area, does it actually really cover the whole craniospinal radiation? And again, we do feel that the Ommaya administration, at least in a more long-term plan, is preferred. And again, typically also preferred by patients because it doesn't hurt the injection. We typically don't have to numb the area much. Maybe we use EMLA cream, but again, we don't need to do literally kind of finding the axis, which we typically have to do with a lumbar puncture. Next slide. And now this is a quick overview of drugs that we have historically and are currently using for intrathecal treatment. And again, I would like to point out that different drugs are being used for different cancers causing leptomeningeal disease. So for example, again, and again, this is by no means to give again, good recipe for a particular case of maybe a loved ones of yours, but just so you're familiar. So methotrexate is very commonly used, as well as cytarabine and topotecan. Pemetrexate is, again, a drug that is also often used, for example, in lung cancer patients. And we have many other drugs that we have investigated in the past that are all chemotherapy based. Now, nivolumab, I did add this here because this is something that we've done at MD Anderson for quite a while and is now also implemented for melanoma leptomeningeal disease patients in the NCCN guidelines. And the dose that we typically use is, again, 50 milligrams. Again, important, most of these have a risk of causing chemical meningitis, which is an irritation of your meninges, because we are accessing, again, a third space, this craniospinal space, the CSF. It can always lead to infections. And again, we can also see transient elevated ICP. Next slide, please. And for the team, I did see the quick reminder that I have 5 minutes left. So again, as I just mentioned, think meningitis. It can cause what we call either a chemical meningitis or maybe an inflammatory meningitis that unfortunately sometimes mimics the symptoms of the LMD by itself. And again, it is very important for us when we're even slightly suspicious to really making sure that we understand cultures, that we do cultures, that we make sure that there hasn't been an infection, which is typically very rare, but again, always has to be considered because it's very treatable. So again, if in doubt, we need to treat empirically with steroids, which can help with the inflammation, and again, treat with antibiotics if we suspect infection. Next slide, please. And systemic, right? So we talked about what can we put down the spinal fluid, what can we give by mouth or by vein. And again, this is really just selected, and this list luckily is advancing and getting more extent by the maybe not by the month, but by the year. And so again, these are treatments that we have tested for patients with brain metastases. So you can see a lot of this is mutational driven. So as again, EGFR ALK can be seen in lung cancer, but again, rituximab is also something that we use for lymphomas or leukemias. Immunotherapy is very important in a lot of solid tumors these days. So again, these are only some of them that are currently already used. And then obviously in melanoma, which again is what I treat, we have BRAF and MEK inhibitors. So again, this list is not exhaustive, but again, I think you can see that a lot of these drugs we really didn't even have 10 years ago or didn't even know about. Next slide, please. And again, the question still remains, well, is it better to give drugs by vein or is it better to give it into the spinal fluid? And the short answer is we really don't know the answer for the individual patient. I just wanted to highlight that we have now a couple of studies with immunotherapies, again, done by one of our dear colleagues, Priscilla Brastianos in Boston. And you can see that her studies really focused on giving intravenous immunotherapy, pembro or ipi-nivo. But the key point was, and this is kind of shown slightly lower in the list, is that none of these patients, which were again just kind of a bouquet of different cancer types that were enrolled in these studies, had prior exposure to checkpoints or to immunotherapies. However, in the melanoma world, which is on the very right side, as you know, most patients that will progress in the brain or with leptomeningeal disease had prior exposure to immunotherapy. And I think this is why we felt putting it down somebody's spinal fluid might overcome levels of concentration and again might salvage these patients. But do we know the true answer? Not really. Next slide. Want to be transparent here. Don't want you to walk away with wrong data. And again, just because it is in the NCCN guidelines, I just wanted to highlight again, it is a tool. We have some patients that have lived now for many years or have lived much longer than we initially had hoped for. But again, the median overall survival is still less than 8 months. Next slide. So the last few minutes, I think I will just spend now how to determine response, but then also just highlight 2 or 3 trials that are currently ongoing that I think you all should hear about. And again, this is a great slide by Dr. Boire. She always makes it amazingly visual. So response, again, continue therapy, that is obviously a good one if we have resolution or improvement of symptoms, if the CSF is clearing from cancer cells, and if the MRI is showing that it's looking better, we continue. Now, if everything looks worse, we need to change therapy. And sometimes in between, it gets a little bit difficult because, again, you know, the CSF we talked about, the sensitivity is very poor, so only 50%. So it is always good and important to do serial CSF evaluations so that we really know, is there progression in the CSF or is there improvement? Next slide, please. The final countdown. And again, switching over to clinical trials. Next slide, please. again, wanted to highlight three that are currently in practice. Now, the good news is if you hit again the button, we'll see that over the last few years, more has happened. So next slide, please. Yes, so there are more clinical trials happen, but again, still overall small numbers. And again, as I mentioned in my initial comments, is we really do need to do better and need to move forward. So next slide, please. And one of the things that we're excited about, again, don't know if this is better than radiation from the outside, is what I would call radiation from inside. So this is rhenium obisbemida. It's done by Plus Therapeutics. And what we do is we inject intrathecally, again, into your spinal fluid, a radioisotope. And the good thing is that, again, that it has a very, again, that you can increase the dose in that particular space, but it's being really leaving your system very, very quickly. And again, this is an ongoing clinical trial, has some clear benefit, but again, the magnitude of benefit still remains to be seen. And again, this is still a small number, but again, they are dose escalating, meaning we're increasing the dose that we're injecting at this point. And again, just wanted to put it on your radar. Next slide, please. Now, this is a slide, again, that I'm very excited, and I have referred patient to Dr. Boire as well. So this is using intrathecal deferoxamine. And so just simply, and again, Dr. Boire is going to give you a much more scientific, better version of what I'm saying. But in short, is what we're trying to do is we're trying to capture or diminish the iron levels within the CSF, because we know that the cancer cells are actually outcompeting for iron with the macrophages or some other of your immune cells. And so what we're trying to do, maybe again, I'm using it in the wrong way, but maybe starving them of one of their nutrients. And again, the phase 1 is complete, and we're currently in the phase 1b exploring further safety of this intrathecal iron catcher, for the lack of better word. Now, please don't go home now and say you can't have meat or can't have any iron-containing foods. This is not how this works. But again, I think an incredible testimony of Dr. Boire's dedication of looking at something in the lab and then translating this into the clinic and finding a potential treatment options for patients. And the last slide that I could have, please, is just making a pitch for our own program at MD Anderson, where we have now moved on from just using nivolumab to using intrathecal nivolumab and relatlimab for melanoma patients, unfortunately. And again, this was based on our prior results. We've treated 8 patients so far with a total planned of 20. And again, the good news is that overall, this treatment has been very safe and with very little side effects. And I think the final slide is really just getting us involved. And I, again, thank you for your attention. I know this was a very quick overview of something that we could speak days for, but again, wanted to thank everybody for their attention, and thank you again.
Thank you so much, Dr. Glitza and Dr. Boire. That was really incredible information and really helpful, I hope, for everybody. We have a lot of questions, and so I want to just dive right in. You both were amazing at answering questions in the Q&A. We don't often have that. So I do want to have one question repeated just to make sure everybody saw this, or if there are any questions around it. But Dr. Boire, can you just define sensitivity and specificity? Because that came up in the slides, and I want to make sure everybody understands what that means.
It was a really good question. It was a nice, good philosophy of science question. So sensitivity is sort of how often you get a positive result, right? So how often the test says yes, right? But sensitivity, so specificity is really more about, is that yes accurate, right? So when the test says yes, is that meaningful? So a sensitive test, we want, like, the perfect test would be both sensitive and specific. Unfortunately, there are very few tests in biology that are both. So we tend to combine tests, and that's really the essence of diagnosing leptomeningeal metastasis, is that you kind of need to combine several tests in order to get to the right answer.
Thank you. That's helpful. And I think that's good for people to understand when they're looking at the various tests and understanding what people are saying when you're talking about sensitivity and specificity. One of the questions that came up, and you also responded to it, but I just think this is really important, is what kind of work you're doing around prevention in the lab and blocking or inhibiting any kind of growth factors. Is there work in that, and what can we expect from that type of research?
So yeah, what I had mentioned was, yes, of course, we're working on this. I think everyone in this space would like to put ourselves out of business. That would be that's the goal. And there is sort of a little bit of a breadcrumb trail that tells us it's possible. So there are a few studies in very small subpopulations of unfortunately children that have certain childhood tumors, where we know that if we treat them with particular regimens, we're able to prevent leptomeningeal spread. And so that tells us that, that the biology isn't necessarily the destiny, and that it's possible to prevent cancer from getting into the leptomeningeal space if we have kind of the right answer. So those are a very small subpopulation of patients. And then in the terms of adults, particularly with solid tumor malignancies, this is a much more complex problem. But I know that in my laboratory, we're certainly working on this using both mouse models, analysis of patient samples, and some different kinds of in vitro modeling to be able to answer that question. So stay tuned. We're working really hard.
That's great. That's what we want to hear, that we're all working towards that goal. We have a question about diagnosing specific cancers and driver mutations. In terms of diagnosis of specific cancers and driver mutations that would target direct targeted therapies or even immunotherapies, are cellular biopsies sufficient for evaluation by next-gen sequencing technologies like MSK Access?
I wanted to answer this one live because it was complicated, but also because it's such a common question that I wanted to make sure we kind of like nail it down. So when we're taking spinal fluid out of a patient, right, there are sort of two parts to it. There's the cellular bit, so the actual cancer cells themselves, and then there's the liquid bit, so the stuff they're floating in the spinal fluid. When we're doing tests of the DNA, I know this is going to seem counterintuitive, but we're actually looking at the floaty bits. We're looking at the spinal fluid itself. What we're sequencing is the cell-free DNA. Cell-free DNA from cancer kind of accumulates in the spinal fluid, and it's actually more sensitive and more specific to be looking at the spinal fluid. So when we're looking at the spinal fluid to analyze cancer in the brain, spinal fluid, and spine, sometimes we can get positive DNA in the CSF and not see any cells. So for example, you can imagine that if you had a tumor that was living on the surface of the brain, not in the leptomeninges, but sort of just nearby, it might shed some of its DNA into the spinal fluid. So we tend to say that we need to see a cell in the spinal fluid in order to be able to diagnose leptomeningeal metastasis, because we want to be able to see that the cancer was in the space. That said, we use spinal fluid for all kinds of other studies, including to be able to do this molecular study, to be able to figure out the molecular characteristics of the tumor, even if it's not in the spinal fluid, if it's in the brain, or if it's in the spine or some other place nearby.
Great, thank you. I know that was a little bit more complicated, so I'm glad you were able to answer that on screen. We do get a question often, and this one's particular to an ALK positive and a CLC diagnosis, but I think we see it a lot, is sometimes CSF atypical cells show up and sometimes there are no cells. And why is that? Why can sometimes you have it positive and sometimes you don't?
I think either Dr. Glitza or Brooke can answer this. So the short answer would be like, we don't often know for sure, but clinical experience says that we do see fluctuations in the numbers of cells and the qualities of cells over time. Sometimes after radiation, for example, we will see kind of a flux of cells that might be dying or dead or kind of ratty looking cells. And this could be a function of just the cells lifting off and dying as they were on the surface of the brain. Sometimes with intrathecal therapies, we see the same thing, where we'll see kind of a brief kind of increase in the number of cells or dying cells or junk or debris in response to that. Other times we don't, and that it's hard for us to say at this point. I want to say when you see the junk or you see dead cells, that means it's working, but I don't know that for sure yet. But I'm totally game to hear what Dr.
No, I think I agree. And sometimes our pathologists come back to us and say, we found one cell and it looks degenerated, just weird, or junk, or really not good. and they try to stain it and it's just not working. So we sometimes can't even say for sure, is this a cancer cell versus a atypical cell? We know it's not a normal cell. And so it becomes really, really hard. But what I would say is that if I see atypical cells, so if I'm diagnosing again a patient, and even though I don't have positive cancer cells confirmed, atypical makes me perk up and be more aware that something is just not right. But again, we've seen this in the past. We used to treat patients with intrathecal interleukin-2, which I didn't even mention, and it was a horrific treatment. Patients would get horrible sick and had really meningitis, were hospitalized for weeks at a time. And what we would see is something that Dr. Boire just mentioned. We would have even patients that had convincing enough MRI brain evidence of LMD, lumbar puncture was negative, but we decided to go ahead and treat. And soon enough after treatment, we would see this surge of deadish cancer cells, and some of them look more typical, some look just like dead melanoma cells, and then eventually it might clear. So it's not an easy one. Those atypicals are very hard, and this is again where we're hoping in the future that other tools like, again, cell-free DNA or circulating tumor cells DNA with a more I'm going to say fancier diagnostic than just the two eyes of a pathologist, will give us a better idea. And I think coming down to one of the questions in the chat too, is some of these newer technologies will allow us to also better measure the amount of tumors within the leptomeningeal disease space. Again, I think some of the tests still need to be more validated and really broader used, and again, are not available at every center for every tumor. But again, I think we're working also in truly monitoring, not only with MRIs, but truly really finding out what's happening within that particular space. Again, the CSF space.
That's really helpful. And I think, we are getting a lot of questions kind of about the whole idea of, can this be leptomeningeal if I haven't had some increase in symptoms, or if everything looks stable, but now all of a sudden I have a puffy left eye and it's tearing, could this be related to LMD even though it seems stable? And what kind of testing or monitoring would we want to do for that? And how does that look?
Yeah, this is a really common question in my patient population. So I will say, particularly with both new immune therapies and new antibody drug conjugates, just kind of glancing over the chat, we have some mentions of Enhertu and some other therapies. Some of our experience kind of clinically with these drugs is still pretty much in its infancy. I have to say that. So often we're not certain if the changes that we see on the MRI, if those are truly leptomeningeal metastasis, or if this is leptomeningeal irritation, right? So usually the answer is to do a careful neurologic exam and to do a spinal tap and to take a look. Very often what we're doing is we're also screening and looking for autoimmune processes, or we're looking to see if there's a particular kind of inflammation in the space, looking for things like oligoclonal bands or quantitative immunoglobulins, this sort of thing. And we are seeing this particularly in different patients. So I would just say, particularly with newer drugs, even though they've come to market, it takes us time in the clinical space to really understand how the brain and the leptomeninges respond to a lot of these drugs. And so it's fair to take a kind of a measured approach to the diagnostic process.
Absolutely. So another question we've been seeing is tumor resistance. And if it finds resistance to a current drug and mutates from the initial gene mutation from the primary cancer, do we know what the path ahead is? How do we determine that?
So maybe I jump in for this one, Adrienne, if that's okay. And again, this is often something we see in BRAF mutated melanomas, right? So, but we also see this in lung cancer, osimertinib, for example, or other things. So I think what happens is in melanoma, at least, we know that the targeted therapies, the BRAF drugs, don't get into the spinal fluid as much as they are in the serum. So if you give this to a human or mouse, the initial experiments were again done in mice, you give them this drug orally and you measure again the blood concentration and the spinal fluid concentration, there's a huge difference, really tremendous difference. And so one of the things that is a thought is that the drugs are just not getting in enough, and that potentially might lead to creation of changes in the mutational profile, or it's just creating clones that are just resistant to lower dose. So one of the approaches we use is going up in the dose. We have a clinical trial where we actually just use a higher dose of BRAF inhibitors for these patients. But the problem is, as you can imagine, that's not a permanent solution, because over time, cancer can become again resistant and come up with new mutations that form kind of an escape route for the cancer. And again, I think this is where we're not that good yet, that we have 5 other drugs that we can kind of then go in with. We sometimes switch them around. There's also other clinical drugs and testing right now, again, in the BRAF world, that is more CNS penetrant, but is it really going to be the more permanent solution? The answer is probably not. But I think this is where we're excited that if we are running excited, where we're running into the thoughts is now we at least have different tools, right? We might be able to offer patients an intrathecal immunotherapy trial. We might then offer patients a radiation approach. We might offer patients going up in the dose. So while we might not able to have, all the drugs that we want to, at least we have different tools that we can try to apply sequentially to, again, help these patients and live longer. And again, I think this is where we really need to advocate, again, as a group with patients and their families, for drug companies to allow us access to much earlier stages of protocols, right? If there's a trial, if there's a drug being tested, if we only think it can actually get into the CNS, we should ask for a few patients just to see that we can potentially help and learn. That's my little advocate spiel here, that I say.
And I will totally pivot and add to that and say, I could not agree more with everything that Dr. Glitza said, including this idea. And it's really, it's fundamental to remember that even though we've been discussing just the leptomeningeal space, that cancer is a whole human disease, right? That this is a whole patient disease. And in the chat, it's come up as well. For many people, leptomeningeal metastasis is not the only site of disease for them. And so often what we're dealing with is kind of a multi-compartment problem, meaning that we have to treat the disease in many fronts. And sometimes as we're sequencing the cancer, we find that we see different mutations in different areas. And that discordance between the central nervous system and the body does happen. And so one opportunity, as Dr. Glitza said, is that we can potentially use access to the leptomeninges, like using intrathecal or intraommia therapies, as a way of targeting just the CNS disease with a particular agent. So, for example, sometimes HER2-driven cancers might gain or lose HER2 positivity in the space. And so you can imagine that you could potentially give anti-HER2 therapy intrathecally and non-HER2 therapy systemically, or vice versa.
Thank you. We are getting so many questions, which I'm so appreciative of, but we really are out of time. So I am going to have to say, we'll look at those questions, see if we can get answers back to people. And I'm sorry we didn't get to everybody, but we will be having more of these webinars. So please know that we will try to answer them. In the last few minutes, I'd love for Dr. Glitza, Dr. Boire, if you could give any final thoughts, sentiments, anything you'd like, any final tips.
I think I just have to go back to the pitch. I think the voice of many is power. And again, I'm very privileged that I have worked with Dr. Boire and some other really impressive, wonderful colleagues in the field trying to tackle L&D. I think for the folks that are organizing this, Helene and Kyle, they know the struggles that we all encountered trying to help loved ones with funding, with research, with getting companies to pitch in. So again, I do believe that having forums where patients and their providers and clinicians can advocate together to push forward is just incredibly important. And so to a degree, you, by just dialing in today, for whatever reason, are already joining these voices. And again, this is really my my frustration over the last 10 years or 12 years of dealing with this. And again, I think Dr. Boire feels again very similar probably about this.
I agree. And I will add, I feel like I say that all the time. I will agree, and I will add that I have to say I'm overwhelmed by my patients' generosity and altruism. That's the thing I would add, is that I appreciate so much that they advocate not just for themselves, but for others. And truly donating spinal fluid, donating samples, donating tissues, all of these things are incredibly powerful. You saw that the disease itself is meant to be quite rare, but 1% of the cancer population, that's actually a large number of people.
Yeah.
And so it's not truly a rare disease. It's, we can overcome those numbers by working together. And so I would encourage everyone that if they are able to, or are if their provider says, would you be interested in donating your any tissues for research, please say yes. It's really helpful to everyone.
Well, thank you both so much. I just wanted to thank you for this amazing presentation. Thank you, Kyle, for all of your help. Thank you to our producer and to all of you, our audience members. Please be sure to follow us on social media, sign up for our newsletter on our website. We will be having another webinar coming up soon on Wednesday, March 5th on radiation therapy. So please register once we get all of that information out to you. I truly hope that this was helpful and that you leave today feeling more empowered, more informed, less alone, and more hopeful. I did see someone's comment here saying the journey feels less lonely today. So that really feels good that we're helping and we're doing what we want to do to make everyone feel supported. So thank you again, everyone, and have a lovely weekend.
Thank you.
Thank you.